In modern gastroenterology, widely prescribed constipation drugs often carry the weakest trial data. Conversely, highly rated modern pharmaceuticals are frequently the hardest for patients to access. Chronic idiopathic constipation, or CIC, affects up to 12% of the U.S. population. It drives high healthcare utilization and impairs patient quality of life at rates comparable to diabetes and depression. To standardize care, the American Gastroenterological Association and the American College of Gastroenterology published a joint clinical practice guideline. The panel systematically evaluated 5 specific pharmacological classes: fiber, osmotic laxatives, stimulant laxatives, secretagogues, and 5-HT4 agonists. By deconstructing the 10 recommendations from this guideline, we can build a practical, stepwise treatment algorithm based on clinical efficacy, mechanism of action, and adverse events. To optimize patient care, clinicians must understand the specific reasons a drug is graded lower. Without this context, highly effective, low-cost baseline therapies might be discarded simply because of historical gaps in their trial data. This PRISMA flow diagram shows the rigorous filtering process applied to the literature. Starting with nearly 1,000 records, strict criteria narrowed the evidence to just 28 studies. This data is spread thin, with therapies like Lactulose relying on only 2 trials. To judge clinical efficacy, the panel relied on strict modern trial endpoints: complete spontaneous bowel movements, or CSBMs, and spontaneous bowel movements, or SBMs, measured per week. The certainty of the evidence yielding those endpoints was rated using the GRADE framework, which classifies data quality on a strict scale from high down to very low, based on factors like trial design and risk of bias. The guidelines output 2 types of directives. A strong recommendation indicates that the drug's benefits clearly outweigh its harms. A conditional recommendation means different choices may be appropriate for different patients, requiring active shared decision-making. A conditional recommendation, or a low certainty score, does not mean a drug is clinically ineffective. It frequently indicates that the available clinical trials were conducted decades ago, long before endpoints like CSBMs were established as the standard. Step 1 of the clinical algorithm begins with low-cost bulking and osmotic agents. The panel issued a conditional recommendation for fiber supplementation, supported by low certainty of evidence. Within the evaluated fiber formulations, only Psyllium demonstrated clear efficacy in increasing bowel movement frequency. Alternatives like wheat bran and inulin lacked robust data. The primary clinical hurdles for prescribing fiber are dose-dependent flatulence and the absolute necessity of maintaining adequate patient hydration. Moving to osmotic laxatives, polyethylene glycol, or PEG, received a strong recommendation from the panel. PEG's data profile is highly consistent. It reliably increases both SPMs and CSPMs, and trial data confirms its clinical response is durable over a 6-month period. By contrast, magnesium oxide, or MgO, received only a conditional recommendation. Its efficacy data stems entirely from highly imprecise, small-scale trials conducted primarily in Japan. MgO carries a critical safety contraindication. It must be avoided in patients with severe renal impairment due to the risk of systemic hypermagnesemia. Lactulose is another osmotic agent that received a conditional recommendation, but its clinical utility is heavily limited by dose-dependent bloating and flatulence. Despite varying evidence grades on paper, clinical management of CIC universally begins with Psyllium or PEG. These agents provide the optimal balance of low physiological risk, low out-of-pocket cost, and proven mechanical action in the gut. When baseline therapies lag, we move to step 2, agents utilized for occasional intervention. Bisacodial and sodium picosulfate, or SPS, both earned strong recommendations. However, the panel explicitly restricts their use to short-term or rescue therapy. These drugs share a mechanism. They are converted by colonic bacteria into an active metabolite called BHPM. BHPM directly stimulates the colonic mucosa, forcing peristalsis. They are restricted to rescue use because this forced stimulation has a cost. While they induce a large increase in CSBMs, they also trigger high rates of dose-dependent abdominal pain and diarrhea. Senna, another widely utilized stimulant laxative, received a conditional recommendation. The evidence base for Senna contains significant gaps. The available clinical trials utilized daily doses much higher than standard clinical practice, and there is a total absence of long-term human safety studies. Stimulant laxatives are highly effective for rapid CSPM induction, yet their aggressive side effect profiles and absent long-term safety data strictly relegate them to intermittent rescue roles. Step 3 involves specialized prescription agents for patients who fail over-the-counter treatments. Lubiprostone is a secretagogue carrying a conditional recommendation. It activates type 2 chloride channels on epithelial cells to increase intestinal fluid. The primary side effect of lubiprostone is nausea. This reaction is strictly dose-dependent and can typically be mitigated by instructing the patient to take the medication with food and water. Linaclotide and placonidine are guanylate cyclase C agonists. Both agents earned strong recommendations backed by moderate certainty of evidence. At the cellular level, these agonists activate CFTR channels. This forces the secretion of luminal chloride and bicarbonate, increasing intestinal fluid and dramatically accelerating gastrointestinal transit time. Both drugs demonstrate robust clinical efficacy in achieving consistent CSPM endpoints. The primary clinical barrier is severe diarrhea, which is the leading cause of treatment discontinuation for these agents. The final strong recommendation belongs to prucalopride, representing the 5-HT4 agonist class. Prucalopride works by promoting enteric neurotransmission. This targeted stimulation induces high-amplitude propagated contractions throughout the colon. The side effect profile includes headache and nausea, but the data shows these reactions are typically transient and resolve within the first few days of treatment. Refractory therapies offer powerful, targeted mechanistic interventions backed by modern, high-quality trials, but they require the clinician to actively manage specific cellular-level adverse events to keep patients compliant. We return to the initial discrepancy. How do clinicians justify prescribing drugs with low certainty grades as their primary frontline therapies? This split comparison chart maps the estimated monthly out-of-pocket costs of these drugs directly against their evidence grades. Legacy treatments sit under $50 a month, while modern prescription agents exceed $500. The AGA and ACG panel explicitly states that clinical implementation cannot exist in a statistical vacuum. Providers must consider these exact out-of-pocket costs and medication availability when selecting therapies. The definitive clinical flow dictates sequencing care. Providers must start with low-cost, low-risk options like PEG and Psyllium and reserve stimulants strictly for acute rescue. Escalation to the expensive, highly rated Secretagogues, or 5-HT4 agonists, is only clinically appropriate when that baseline combination of over-the-counter interventions fails. Currently, the guideline relies primarily on placebo-controlled data. There is an urgent need for head-to-head network meta-analyses to compare these active treatments directly against one another. Pharmacological management of CIC relies on shared decision-making. Clinicians must weigh a drug's statistical efficacy against the patient's physical tolerance and financial constraints.